wait. Shruti ma'am, please wait.
Now start, Shruti.
Good afternoon, everybody. I welcome you all today for the FOGSI ICOG Guru Mantra session. We have Dr. P.K. Sekharan giving us a wonderful talk, gonna give us a wonderful talk on GTN and their current concepts. But before that, I would request Secretary ICOG Dr. Ashok Kumar to please welcome the audience and say a few words.
Yes, good afternoon, good evening to all of you. And we welcome you all for this ICOG Guru Mantra series. And this is the initiative of our chairperson, Dr. Lakshmi Srikhande, who is here today also. And this year she has started a lot of web series and a lot of programs. And I hope you must be getting all the information and enjoying all these webinars, which are full of all information and knowledge. And with these words, I would like to thanks all the participants, speakers, conveners, and for this program. They have organized this program today, and where we have Dr. Sekharan, who is a legend for and final authority in when we talk of HMOL and all these issues. So we have his expertise and knowledge today. He will be sharing with us all the details. And this talk, I'm sure that it will be very useful to all of us for clinical practice. And I also would like to welcome our Vice Chair, Dr. Parag Beniwala, and Dr. Lakshmi Srikhande, Chair ICOG, for this webinar. And I'm thankful to Dr. Sarita Bhalerao, Dr. Priya Ganesh Kumar for this wonderful meet. Thank you very much.
Thank you, sir. I would request our chairperson, Dr. Lakshmi Srikhande, to say a few words.
Yeah. Thank you, Shruti. First and foremost, I would definitely say that we are so happy to have Dr. P.K. Sekharan with us. He is teacher's teacher. And as Dr. Ashok has already said, he is the final authority when it comes to gestational trophoblastic neoplasm. So, sir, along with all the delegates who have logged in, I am also here to learn the tips and tricks and nuances of managing gestational trophoblastic neoplasm. And for this Guru Mantra web series, I must acknowledge the efforts taken by Dr. Sarita Bhalerao. And Sarita, it is really going great guns. I welcome our Vice Chair, Dr. Parag, Secretary, Dr. Ashok, our all the chairpersons, Dr. Niranjan, Bhagya Lakshmi, and Dr. Priya Ganesh Kumar for this Guru Mantra web series. And I also like to welcome all the delegates who have logged in to learn from our teacher's teacher, Dr. P.K. Sekharan. So welcome all, and I hand over back to Shruti for further proceedings. Sarita, she is on phone. You can take over.
We request Dr. Parag Beniwale, Vice Chairman of ICOG, to say a few words.
Sorry, this is the Dr. Niranjan Chavan. He's logging in now. So
yeah. Good evening. I bring greetings from ICOG, and this is the second episode of Guru Mantra, the initiative by the ICOG chair, Dr. Lakshmi Srikhande. When we talk about GTD, only one name comes in our mind, and that is Professor Sekharan. We were lucky to have him in one of our web programs of Pune OBGYN Society a couple of months ago. And it was a great learning experience even then. So we are looking forward to another exciting session today. We would be happy to have you as a speaker. Thank you very much.
Thank you, Dr. Beniwale. Without further ado, I'll let me begin the session by introducing our chairperson.
Shruti, I'll just do a vote of thanks,
Sure.
And then,
Sure.
yeah. So I'd like to begin by thanking our FOGSI President, Dr. Rishikesh Pai, for all his encouragement. A big thank you to Dr. Lakshmi Srikhande, who's been the guiding force behind this program, and for all her tremendous help. Thank you, Parag. Thank you, Dr. Ashok, for this program. A big thank you to Dr. P.K. Sekharan sir, who readily agreed. And my apologies for the changes in dates. You know, the ICOG calendar is so full that it is difficult to adjust everything. And this was a little bit delayed because we had the AICOG program. But thank you so much to agreeing at short notice to lecture in this program. A big thank you to our chairpersons, Dr. Niranjan Chavan, Dr. Priya Ganesh, and Dr. Bhagya Lakshmi, who have all three been oncology committee chairpersons of FOGSI. So I really think that we have a wonderful, set of chairpersons. And thank you to Shruti for her Master of Ceremonies, and to all the technical and the office staff, and of course to all the delegates who logged in. Thank you.
Thank you, ma'am. Thank you. We'll begin by introducing our chairperson, Dr. Niranjan Chavan. He's the professor unit at Sion Hospital. Plus, he's the president MOGS, current president MOGS 22-23. He's also a joint secretary AFG.
Can we display the CV?
Yeah, Shruti, display now. All the CVs are with you, please.
Okay, I'll have to.
Yeah,
I just thought Nilima is doing.
I think the technical people have the CVs. They are going to share the screen.
Komal?
Ma'am, Nilima ma'am told that Shruti ma'am will display.
Share.
Okay.
You want me to display? Sure.
Okay, doesn't matter, Shruti. Go ahead. Don't worry if it's not possible.
Yeah, I will have to then do the sharing thing.
Don't worry. Go ahead. You read.
Give me a minute. I can do that.
Komal,
Sure. So
Yes, ma'am. Yes, ma'am. Should I share it?
yeah,
yes,
please. Please go ahead.
we can. Yes.
Yes. No, not a Niranjan. Yes.
Yes. Dr. Niranjan Chavan, he's a president MOGS, current president MOGS 22-23. He's also joint treasurer FOGSI, current 21-24. He's a professor unit head at Sion Hospital. He's a joint secretary of AFG, coordinator of various batches of MOGS, and has received various.
Thank you, Shruti. It's okay. Thank you.
Welcome, Niranjan.
Welcome, sir.
Thank you, madam.
Dr. Bhagya Lakshmi Naik, she is a current HOD at the Department of Gynec Oncology at Cuttack. She's also chairperson Oncology Committee at FOGSI and a governing council member of ICOG. She's also vice president of AOGI in India. Welcome, madam. Dr. Priya Ganesh Kumar.
So much. Yes.
She's a chairperson Gynec Oncological Committee FOGSI 21-25, and she's a medical director at Srinivas Healthcare. She's had various books and publications under her name, and I would welcome madam. I would request Dr. Chavan to introduce our speaker.
Thank you, Dr. Shruti. Thank you, Dr. Lakshmi Shrikande, our ICOG chair. Thank you, Dr. Sarita Bhalerao, the convener of the program. And it's a great honor and privilege to present to you Dr. P.K. Sekharan. Sekharan sir and I know each other probably for more than 2.5 decades. He has been the vice president of FOGSI. He was also the chair of Norms and Nomenclature Committee. Very few of you might be aware that he was the chairperson. And then that committee was then dissolved, and that was where he did a lot of work during that tenure, as I was a member in that committee on maternal mortality. His main forte is gestational trophoblastic neoplasm, and he has got a lot of awards, and he has given orations for the same. He was also the secretary and the president of the International Gestational Society for the Study of GTD from 13 to 17 as a secretary. And of course, he was the president of Kerala Federation. Sir, I know in person, and he has got a lot of knowledge on gestational trophoblastic neoplasm. So it's an honor that you have been selected today and you are giving your valuable time to us. We are all eagerly waiting for your lecture. Thank you so much for being there with us.
Thank you. Can I start sharing my screen?
Yes, sir.
Yes, sir.
So thank you very much, Niranjan, for that kind words. We know each other for nearly 3 decades, not 2.5, almost 3 decades now. Okay. And Dr. Rashmi, of course, I know her from her initial stepping into the FOGSI, and then she has gone to very great heights. Now chairperson. Dr. Bhagyalakshmi, of course, I know for some time, quite a few years now, and we are all close friends. Dr. Paragwala, again, for years together and being together for so many occasions. Dr. Ashok and Dr. Committee chairperson, I forgot mentioning her name. I mean, the committee chairperson, I'm getting her name. I know her very well. Thank you very much all for your kind invitation. And we all know that gestational trophoblastic neoplasia is the most curable gynecological malignancy. Not only that, we get a cure, almost 100% cure in low risk cases, and they are retaining the reproductive potential to bear children afterwards, after getting the treatment. So this is a rare tumor that way, and it is becoming rarer nowadays, so that people are not much experienced of seeing and treating such cases. That creates the problem. So since it becomes fewer and fewer incidence is coming down, like mainly because of the reproductive potential of the young girls and elderly women, we were utilizing the past. Nowadays, the very young girls are not becoming pregnant as well as the elderly. So one of the most important etiological factor is the reproductive age of production at the extremes of life, reproductive life, teenage as well as very elderly. So that is getting down, and that is the only reason why the molar pregnancy is coming less. People are telling that it may be rice eating and other things, this thing, that it is not. The main etiological factor is the reproduction at the very extremes of life, and also the condition are being diagnosed nowadays much early. That creates some problem also, we'll see to it. So that is the present stage. We can get a cure, 100% of cure, and even in high risk cases, we can achieve almost 90% cure. So that is the situation. We know GTD and GTN are two terminology that we must understand. It's nothing special. GTD includes the benign, and GTN includes the malignant. Everything from the benign to the malignancy is grouped as GTD, gestational trophoblastic diseases, which includes complete and partial mole, the pre-malignant or the benign variety, the invasive mole, choriocarcinoma, and persistent elevation. You may not see any other diagnosis, just elevation as we diagnose GTN there. So these are the cases following molar pregnancy and develops from the chorionic villi. Now, the placenta-site trophoblastic tumor and the epithelioid trophoblastic tumor, just 1% of all the GTN, maybe 1 in 100,000 deliveries, we may get this type of GTN also. And these are from the intermediate cells. The two types of the intermediate cells that we develop these type of rare tumors. So just to understand that, in a chorionic villi, we got the cytotrophoblast outer layer and the syncytial trophoblast, from where we get the hydatidine mole, from where you develop the GTN. The rare types of the placenta-site trophoblastic tumor is arising on the implantation side intermediate trophoblast. They are not from the villi. This is the origin of that. So whatever is the pregnancy, and usually these are following normal delivery, not molar pregnancy. And the epithelial type is actually rarer, and it is from the intermediate cells of the chorionic type of intermediate trophoblast, which is the chorionic type on the covering of that membrane. So that is the origin of all these tumors. Now, cytotrophoblast is the trophoblastic stem cell, and syncytial trophoblast is formed by fusion of the cytotrophoblast and the intermediate trophoblast, which is leading to the very rare type of the PSTT and ETT. The syncytial trophoblast produces HCG, human placental alkaline and placental as alkaline phosphatase. After 8 weeks, the HCG comes down considerably and only a lower level, but the HPL and the placental alkaline phosphatase increases. Now, just to something onto the genetics of the mole, the molar pregnancy is an abnormal fertilization. It develops due to abnormality of the ovum, basically. The ovum in complete mole is losing its nucleus. And this empty ovum is getting fertilized by a sperm containing 23 eggs, which duplicates to form the 46 sex component to have the complete mole. So mainly 80% or more of such moles are by duplication of the single sperm into the 46 chromosome component to have. And this will have uncontrolled proliferation and growth and high potential for malignancy. While in partial mole, there is a nucleus of the maternal component is still there, which is getting fertilized by 2 sperms. The ovum should not allow more than 1. So here is again some defect in the fertilization, and 2 sperms are getting in to form the cystine XXY. Usually it can be cystine XYY also. And that is also the proliferation and malignant potential in partial mole is very less. Now, there's another component or variety of the mole, what is known as biparental complete hydrogenome mole, where there is a nucleus of the maternal ovum is there, but it is having some imprinting defect or silencing of the chromosomes, and this manifestation is mainly of the male component of the sperm containing 23 XX. So the component may be 46 XX, but it is only of the sperm, not of the maternal component, due to some genetic defect, and the genetic mutation is found out to be NLRP7 in majority of the conditions, and a few percent of them will have KHDC3 normality. So these are very rare types, but there are cases where familial recurrent moles are happening in sisters, and they may not have a chance of having a normal child. That is the problem. And there's a higher potential for malignancy. So that is something about the genetics. Now, Hydatidiform mole earlier on was very easy to make a diagnosis. Just the moment she comes with some irregular bleeding and a big uterus, you just keep the probe onto the abdominal wall, you get very classical finding of the complete mole. Maybe there is association with the theca lutein cyst, bilateral. And in the partial mole, there is a fetal or fetal component is there, and the placenta will be showing that molar change. And the evacuated product, you don't have to even study histopathologically because it is so evident. So this was the situation about 20 years or 15 years back. Now things have changed. So there is no confusion in the clinical diagnosis, big uterus, hyperemesis, even early onset preeclampsia, everything is not there nowadays. What is there today is patient will have a missed period for 2 weeks or 3 weeks. They'll do the pregnancy test and come with a positive pregnancy test. Usually irregular bleeding may be there, or just to know whether she is having a normal pregnancy or not, they will come with the test. Sometimes they may even come with ultrasound finding. So anyway, whatever it is, you may find this early pregnancy signs are there. You may even offer a ultrasound because patient is insisting to know whether the pregnancy is normal or not. So on ultrasound, even if it's a complete mole, what you are going to see an irregular sac, empty sac, or something like this, and may be diagnosed as irregular gestation sac, an embryonic pregnancy, or missed abortion. And once you get a diagnosis like that, usually they will undergo medical abortion. Abortion may be taking place outside the hospital. No chance of doing a HPR or no HCG follow-up. It has been seen that even if you evacuate the mole at a very early stage, the potential for malignancy is the same. She will develop malignancy if it is just trying to develop the malignancy. So early evacuation doesn't prevent the chance of GTN there. So what will happen is they are all going to come at a later stage because there is no follow-up, there is no suspicion that it was a molar pregnancy, and it is a medical abortion, no tissues are. So that is happening nowadays. Just in the month of, I think, this was month of December, this patient has come to us at 7 weeks or so. Earlier picture, you can see, you can't make out that it's a vascular mode, but it's something looking abnormal. The patient was asked to come after 1 week to re-evaluation, but she came after 2 weeks with the nausea, vomiting, like severe vomiting. And since we had that suspicion, of course, of abnormality, the scan was done. Now it is 9 plus 10 weeks, around 10 weeks. Even though it is not that florid, very clear picture of a snowstorm appearance, it is very suggestive of molar pregnancy. So any pregnancy which is a molar pregnancy before 9 weeks, the classical findings of a molar pregnancy will be missed, and the diagnosis will be missed as a missed abortion and a medical abortion, no histopathology. So that is what is happening nowadays. This particular patient had more than 2 lakhs of HCG before evacuation, but after evacuation, she is being followed up. Priming gravida, she is under follow-up. So this is what is happening. This is the actual sequence of one of the case. Initially, we are having suspicion that this abnormality is there, but it is not suggestive of a molar. And you may even advise a medical abortion. So even if that happens, what we can try to do is that to do a urine pregnancy test 3 to 4 weeks after evacuation. Now, in a normal delivery, the HCG will disappear in 2 weeks' time. If it is an induced abortion, it may take 4 weeks. And if it is positive beyond 4 weeks, you have to re-evaluate that patient. So that's a simple trick of not missing such a case where the patient had an abortion, evacuation, medical, otherwise should have a urine pregnancy test after 1 month. That is the simple thing. And if it is positive there, then you have to have an evaluation. This is the only way of picking up safely. It is very difficult to order for histopathology in all abortions also. But this simple rule of doing a pregnancy test after 1 month in any abortion is going to help us to pick up such cases. So that is one scenario what we are facing today. And this is what we have to do to escape from that, missing that case. Now, GTN may develop mostly from complete mode. Complete mode has got a potential of going for GTN, which is not choriocarcinoma, which is by definition maybe a plateauing or rise in HCG as per that rule, or can be an invasive mode mainly. Only about 3% of the vascular mode will develop into choriocarcinoma. But all other things are GTN, need not be choriocarcinoma. So complete mode has got a higher potential for developing GTN. Partial mode, even less than 1% to even 5%. That's all. And 50% of the GTN are following unattached form mode, mainly following complete mode. And this is forever I started reading this presentation is coming that 50% following attached form mode, 25% following abortion, 25 following term delivery. Actually, nowadays, nobody has done a clear evaluation of what is happening. But we are just following what is in the textbook and otherwise. Somebody has to look into this, whether it is really so, and including abortion, including pregnancy. So we do not know actually what is the result. But this is being quoted for the last 30, 40 years, like this. This figure is seen in every textbook. 2 to 3% may progress to choriocarcinoma. GTN following molar pregnancy can be diagnosed early by regular HCG and clinical follow-up. That is the beauty of picking up the case at the early, so that you can have 100% cure, retaining the potential for reproductive function. It is not necessary to have histological confirmation when you have we are making a diagnosis of malignancy on the marker, and you treat the case as a malignancy with the chemotherapeutic agents with the marker. No histopathological confirmation is necessary. In no other malignancy, we are allowed to do that. I hope Dr. Bhagyalakshmi will support me. No other malignancy, we are supposed to do give treatment without histological confirmation of the malignancy. But this is the only one which we treat on the marker. Now, diagnosis of GTN following a vesicular mole or adenocarcinoma mole is easy because if you do the clinical follow-up. HCG once in 2 weeks is good enough. If not, if you can do it once in a week, is better. But once in two weeks also, it is good because you are not going to miss any cases. A rise in HCG values over 2 weeks. A rise of HCG is not doubling or other things, just more than 10% of the previous value is a rise in HCG. Or plateauing, which is a fall less than 10%. The fall of the HCG in the consecutive weeks are less than 10% is 4 such values are taken as plateauing. So both this occasion, we are with this alone, we are making a diagnosis of GTN and they have to be treated. Or persistence of the HCG after 6 months is also taken as 7. There was some other issues. There are people who are still following beyond 6 months. They don't just start chemotherapy, but in our country, I think we should not miss a chance of curing the condition with a single agent. So we will take it as a chance. The normal fall in the HCG after evacuation is by a log. A log means 1/10 of the previous value. So that is the normal thing happening. But in case of GTN, we are giving allowance. At least it should be more than 10% of the previous value. The other one is 10 times. So even if that is not there, then we have to take it as a case of GTN. Tissue diagnosis, if happen to be, then it is of course GTN. The management is depending upon the stage and the score. The moment you make a diagnosis following vesicular mole evacuation and HCG follow-up, you see that it GTN, you are not just to start the treatment with any drug. You have to decide which drug or which combination we have to give. That is, you have to stage the disease and score. The risk scoring is important there. And you have to do the staging with the evaluation of the metastasis if there is anything. So definitely ultrasonography with the Doppler will help us to see anything on the uterus. Chest X-ray or CT chest. Chest X-ray is sufficient as per the still the guideline, most of the guidelines except chest X-ray. If there is no lung metastasis, no further evaluation is required. You can stage it as stage 3 if you see, and stage 2, or if there is a vaginal nodule. Otherwise, it is early stage. So staging is done with the metastatic workup. If it is involving lungs, then you have to do everything. MRI brain, CT abdomen, MRI liver, everything has to be evaluated in a case following molar pregnancy. Now, this is the metastatic work that we are talking about. You have to do a pelvic ultrasonography with the Doppler. Sometimes you may see the very vascular nodule in the uterus with a very high blood vascularity. Chest X-ray may show a nodule, that means it is beyond the uterus. So it is stage 3, and you are supposed to do all other investigation to rule out extension to other distant organs like liver, brain, etc., or other tissues. So if the chest is clear in GTN following molar pregnancy, no further evaluation required. If it is positive, you have to do everything. Yeah, sometimes the patient may come with a vaginal nodule which can bleed profusely. Do not biopsy the nodule, it will produce torrential bleeding. Now, this is the flowchart for following post adenocarcinoma mole, pelvic ultrasonography, chest X-ray, suspicious, you have to go for CT chest, and if it is positive, naturally brain MRI. If it is normal, no further test. But any case following delivery, abortion, or a relapse of the case which you have treated, then you have to do every examination. So following delivery or a relapse of the GTN following adenocarcinoma mole, she has relapsed after treatment, you have to do every possible investigation like pelvic ultrasonography with the Doppler, CT chest, MRI liver, brain, or even PET scan. So this is the thing. So after making a diagnosis, you have to make a staging. For staging, you have to know what is the extent of the disease. In vesicular mode, following a GTN, following a small, just to see whether the chest is involved. If not involved, you make a diagnosis, not further. So stage 1 confined to the uterus, 2 outside the uterus, but limited to the genital organs, that is including vagina. Vagina nodule is stage 2. Stage 3 to the lungs, with or without genital tract. And stage 4, all other metastatic states like liver, brain, everything. So this is the stage. So stage is not sufficient to again to decide on the chemotherapy. You have to score the disease also. Now scoring is initially proposed by FOGSI and later on taken up by WHO, and now FIGO has modified it. Now FOGSI score or the WHO score, there is a blood group and other thing which we have omitted. Also, liver and brain is given the maximum score of 4. So accordingly, you should have the chart if you can't remember it. Otherwise, you have to, whenever you make a diagnosis, score the disease. If the score is equal to or less than 6, it's a low risk case. If it is more than 7 and above, up to 12, it is high risk. And now there is a group what is classified as ultra high risk, which is 13 and above, is known as the ultra high risk. So this treatment approach to all these groups are different. So treatment decision for treatment, starting the treatment depends upon the stage as well as the score. If it is a stage 4, naturally it is multi-agent. If the score is, the stage is 2 and but the score is more than 7, it is high risk case. Like that, you have to put together everything. So it depends on the management, depends on the chemotherapy, depends on the. Can I move this one? I can't see it. Okay. Management depends on the stage and disease. Stage 1, 2, 3 with risk score of 6 and below, it is a low risk. Even if it is stage 3, which is lung involvement, you can start with single agent. Stage 4 or the risk score is 7 and above to 12, it is high risk and you have to start multi-agent chemotherapy. Ultra high risk, there is observation for the last few years that if you start the PACA multi-agent therapy, tumor lysis and bleeding will occur and they will develop complications and early death has been reported. So you start at a lower dose of 1 or 2 agents, stabilize the patient and then start the chemotherapy, what is known as the induction chemotherapy that has come up. Now, which single agent has to be given? There are a lot of, there was no confusion earlier when we started because there is no RCTs and other things on the GTN-like situation. It was the single, the author's experience or the hospital experience from which we were treating. We have borrowed the experience of people from US and the UK, especially Charing Cross, to start the treatment at that time. But now there are some studies are coming challenging the superior methotrexate and actinomycin T. So, which is the most effective, less toxic, and better tolerated drug if you choose which single agent to be given? So, one of the Cochrane study in 2016 is before that also there was a study. They have challenged the superior to methotrexate and said that actinomycin is better. But at that time also we were in the group. I was discussing our experiences. Otherwise, I was telling them our results is superior, much superior than this because first thing it was a very low risk cases, and we were very conveniently using the regime of methotrexate folic acid, which was very much used in UK at that time. So what they have combined is weekly methotrexate with actinomycin D. So when you see the Cochrane review like this, the statement is that first line methotrexate may be more likely to fail than the actinomycin. That is the conclusion, which is otherwise. So what they have done the comparison is weekly methotrexate with pulse actinomycin D. We were giving the multi-day. They haven't tried with the multi-day methotrexate with actinomycin D, and that has shown different result. we were also arguing for the multi-day methotrexate, even if it is methotrexate alone 0.4 milligram per kilogram body weight given over 5 days. IM or IV was giving better result, even if it is not 8-day regime of methotrexate folic acid. But this is a Cochrane review, which has put too much of our belief to otherwise. But the comparison was different regime. So we were talking at that time, and later on in 2020, there was a phase 3 trial, and they have definitely proven that multi-day methotrexate had a 88% complete response rate compared to biweekly actinomycin D, 79%. So it was otherwise showing the opposite result. And the survival rate, whatever is the regime given in these early cases, were 100%, whatever you start. But we were always happy with the multi-day methotrexate folic acid. And this result has given us a lot of support that we can continue with the methotrexate as a first single agent. Then the policy is to go in for actinomycin D if they do not respond well. Both drugs are effective, but we thought actinomycin is slightly more, having more toxicity than methotrexate. Like alopecia and other things are more commonly seen in actinomycin D compared to methotrexate, what we were giving. There was some case of mucositis and other situations were there, but it was all mild. So we were very happy and continue with that methotrexate folic acid regime. So low-risk GTL, now we can settle to a situation that we can start methotrexate folic acid regime, the multi-day regime of giving 1 milligram per kilogram body weight on 4 days on alternate days with the folic acid 0.1 milligram IM. You are all giving it as IM and repeated every 2 weeks. You have to do the CBC, LFT, RFT prior to every course and beta SCG to see the response. Every 2 weeks, you have to do this investigation because it is the drug is both myelodependent, all rapidly multiplying cells will be destroyed, including the normal cells, not only the malignant cells. So you have to see whether she is anemic or not. Once she is responded well, you can give 2 to 3 courses. Some of the people are giving 3 courses after. We are giving 2 courses after the complete response because it is low risk, but it is no harm done other than slight toxicity and inconvenience. You can give, to be sure that no relapse occurs, you can give 3 courses. The other regime is 0.4 milligram per kilogram daily, which may come to 25 milligram into 5 days without any folic acid in between. Actinomycin D is also effective, 0.5 milligram IV assay or 10 to 12 microgram per kilogram body weight, which comes to about 0.5 milligram IV for 5 days, repeated every 2 weeks. The problem here is if it extravasate, it will cause local sloughing. So be careful in giving IV actinomycin because it can cause local sloughing and you can have problem. Pulse actinomycin D is also effective, repeated every 2 weeks. So it has been proven now concluded that multi-day methotrexate is used as a first-line therapy, and in cases where the response is poor, you can go on to actinomycin D. Both are effective. If you are a fan of actinomycin, there is no harm. You can start with the actinomycin D. Only thing is both are effective, but we reserve the actinomycin D for cases which are not responding well or where you cannot give the methotrexate and you can fall on to actinomycin D, which is a very good drug. We are not having much familiarity with the etoposide as the primary one single agent or 5-fluorouracil, but those are also being used in the Chinese by the Chinese group. Now, weekly methotrexate is not recommended as per the NCCN latest guideline. So that was a confusion early. We do not recommend methotrexate weekly. Now monitoring during chemotherapy. So that's a chemotherapy that we give 3 courses after complete remission, after it has become negative. You have to see the SCG every 2 weeks at least. If the fall is less than 10% over 3 courses or rise in HCG more than 10% over 2 courses, you have to make a diagnosis of drug resistance. Don't just keep on giving a single agent. You have to see the response. If the weekly HCG or 2 weekly HCG is not falling as expected of more than 10%, then it's a case of drug resistant. If there is a rise for 2 courses, then you have to. So once you make a diagnosis of drug resistant, don't keep on giving that drug. Don't give it for 10, 15 courses. She's not going to, sorry, going to respond because you are going to produce toxicity alone. So if she becomes resistant to one single agent, you can choose the other agent, provided the HCG at which level the patient has relapsed or shown the ineffectiveness of that drug. There is a consensus that if the HCG is less than 1,000, you may use the alternate single agent. But if you are having a diagnosis of choriocarcinoma, don't play like that with the single agent. You can go on to the multi-agent therapy. If the patient is multiparous and not desirous of more childbearing, and if it is confined to the uterus, we have seen that you can do a simple hysterectomy, leave the ovary there, even if it is showing lutein cyst, leave it there, and you can get a better cure, a faster response to single agent. So that also we have shown that it is possible. So that is the option when there is a less response to single agent. Surveillance, we said HCG normalization, then give 2 or 3 courses more. Follow up with HCG every 2 weeks. It should be negative for 3 such occasions. That means every 2 weeks means 6 weeks. Then go in for HCG for every. This is the case where the response is good. She has normalized. Still, you give 2 or 3 courses more. Follow her with 2 weekly HCG for 3 occasions. That means 6 weeks. And then it is sufficient to do it for once in a month for 1 year. During this period, you have to advise contraception. After that, she may try to conceive if desired. But if somebody becomes pregnant during this period, not to terminate that pregnancy. She has normalized, the HCG has normalized, then only she has ovulated and become pregnant. So nothing wrong with that. But usually we will allow them to, want them to have a 1 year of avoiding pregnancy, because we want that whatever effect of the chemotherapeutic agents on the ovary may be reduced or washed out during every menstruation beyond that. That is the hope. But there is no hard and fast rule. If somebody conceives in between, it is because of the normalization and she can continue with the pregnancy. And we had such occasions where the pregnancy was continued, nothing happened. There was an unfortunate situation of termination of pregnancy because patient has come after some time. She was on chemotherapy. She had amenorrhea. The beta HCG was very high. No ultrasound was done. Uterus was bulky and tried to terminate. It was a normal pregnancy. So whenever she comes like that after the treatment, she can be even having a normal pregnancy. Don't disturb it. Elderly women treated with Emaco, if they want to conceive, let them conceive early, say after 4 months or 6 months, not after 1 year, because they are at risk of developing menopause at an early stage, early age. So if they are above 35, not wanting to conceive again, allow them 6 months at least follow up and waiting for 6 months. And because they may go in for amenorrhea because of the ovarian failure. So allow them to conceive after 6 months. Now, there is a special group in the FIGO score, which is low risk cases, which is known as 5 and 6. We were all treating the very early cases compared to the present situation. We were not having very late cases coming. So group 5 and 6 in the FIGO score, though grouped as low risk, the response to single agent chemotherapy may be poor. Low threshold for combination therapy. You have a thinking that you may try single agent, but I am ready to shift on to multi-agent if she is not responding. Because you are getting at least 30% cure rate, start with a single agent so that you are not producing severe toxicity of the multi-agent chemotherapy. You can get a cure at least in 30 to 40% of this score 5 and 6. So why not get that? Even if you are treating and not responding to single agent, subsequent multi-agent therapy is definitely going to be curative. So you can choose that way. There's no harm in starting single agents and try to continue with that. Resistant cases can be salvaged combination therapy with 100%. Even if they show resistant to single agent, you don't miss anything. You can get 100% cure by single multi-agent therapy. So here there is a place for single agent therapy, even if it is group 5 and 6, the response to single agent is poor, but there is a response for at least 30-40% of the cases, and you treat with single agent with a less toxicity and get a cure. Others are treated with a multi-agent without losing much. Drug resistance is diagnosed when there is no response to single agent, as we said, 3 weeks or 2 weeks, and you have to do the metastatic workup. Sometimes the disease might have progressed, or originally your diagnosis early stage may not be correct. Whatever it is, you have to do a metastatic workup, rescore the disease. Accordingly, you start with single agent or multi-agent. You can use the alternate single agent if it is still in the lower risk group, but if it is high risk, definitely you have to. So without doing that, if you keep on giving the same single agent, you are not going to cure the disease, and it may become very difficult to get a cure. In such a situation of drug resistance or delayed action of the single agent, we can confine to uterus, you can do a hysterectomy, and then another single agent will get a cure, as we have seen. Now, multi-agent, we know the imaco is the first line of choice. We give the 8-day regime. You don't want to bore you with these details, which everybody, if they are treating, will be available with them. Ultra high risk is a situation where tumor collapse, hemorrhage, necrosis, septicemia, metabolic acidosis, multi-organ failure, which may lead to death if you start the standard combination chemotherapy, because it is very high score. So to avoid death, it has been now shown that you start with a low dose of what is known the induction chemotherapy with the etoposide and cisplatin before starting the imaco. Etoposide 100 milligram per meter square IV on day 1, and cisplatin 20 milligram per meter square IV on day 2. And repeat every week. 2 or 3 courses. Then there is a considerable improvement in such very hopeless cases, and you can get up to 60-70% cure rate even these very ultra high risk cases if by going to this induction chemotherapy. Now, salvage chemotherapy, when the patient is showing relapse or incomplete response, you change over to IMA-EP or EP-IMA, that is the rate of complete response after IMA. Is about 70-80% only. 20% we may have to think of other combinations, and there is so many things. TPT, so many things can be tried. There is no end to chemotherapy in this difficult case of GTN. TSTT and ETT are basically less responsive to chemotherapy. There's no FOGSI risk score in this case. Treated with surgery if confined to the uterus. Lymphatic spread is present, so you have to sample the node. The most important prognostic point in PSTT and ETT, the interval between the last pregnancy event and the presentation of the case. If it is more than 4 years, 48 months, the prognosis is very poor, and almost 90% plus of patients cannot be salvaged. They cannot be cured or can be served. So the diagnosis is very delayed because there is no specific symptoms. There is the patient may come with a case of AUB. Once you do a curettage, you may be lucky to get it. The tumor marker SCG is not very evident in these cases. HPL is not easily estimated in any case. So luckily you may get in the SCG the curetings, or sometimes the local vaginal metastasis may be seen as in the case of ETT. So very difficult to make a diagnosis. Very rare situation. 1 in 100,000 pregnancies or 1% of the GTN. So it is rare. The ISS did that the International Society for Study of Trophoblastic Disease collected about 78 cases of PSTT over the last 5 years. And we are getting that there's a database there. So that is the experience what we have. So it's a rare disease, but curable if it is diagnosed in the early period. Salvage chemotherapy, when the patient is responding to anything, IMACO, you may go on to IMA-EP, TP, everything. There are so many things, as Dr. Gileshmi may be trying all those things. We are not very familiar with treatment of chemotherapy agents. So you can try. Approximately 20 to 25% of GTN will be resistant to all cases after initial chemotherapy. Or resistant and relapsed lesions may require salvage chemotherapy, and you can go for other agents. So there are other options. Surgical resection of isolated drug-resistant masses like lobectomy, hysterectomy, craniotomy. I know one patient with during pregnancy developed metastatic disease. She had to have craniotomy, and then the pregnancy was pulled up to 27 weeks. The cesarean was done, and she was cured with a multi-agent chemotherapy. So even with the brain metastasis, she is now wanting to have another child. That is the situation. So that is there. So you can get a cure in many cases of GTN. Now the next thing is immunotherapy in GTN. Recent evidence suggests that GTN might be an ideal candidate for immunotherapy. That we know the programmed cell death 1, PD1, and the ligands PD1 and 2. According to that percent, there is what you know as immune checkpoint inhibitors, anti-PD1, anti-1, 2. What you know, pembrolizumab is one of the drug tried. Avelumab also has been tried in case of very resistant cases. Though there are cases reported from various parts of in France, they have tried this drug in drug-resistant cases. So there are some success seen by this immunotherapy. Now immunotherapy is being used in many malignancies, so that is being utilized in GTN also very resistant cases. This was a case report showing that the patient had IMACO 11 cycles, IMA-EP 5 cycles, TPT 7 cycles, 4 cycles like that. And then this patient was started with pembrolizumab. After 3 cycles, her beta HCG became negative. And 16 months after the 6th cycle, she was disease-free. So there are hope for such situation. Probably as we see, the modification for the T cells also is being tried to treat malignancy. So things are improving. Such a difficult case also getting cured with these agents now. Now, just to show what we could achieve in about 15 years time, we have reported this, our result in an international journal. During this period of 1990 to 2005, we had 1,746 cases was small, both included partial and complete. The GTN was diagnosed in 356 cases, 20%. Complete remission with the methotrexate folinic acid alone. So these are all early cases, was 88%. And some of the cases which was not showing that response to chemotherapy, who are multiparous, who are having some irregular bleeding, either bulky uterus like that. We did hysterectomy in 14 of them, which is 3.9% of the total. And quickly after that, with the single agent, they achieved complete remission. So the disease burden or tumor burden will help us to achieve remission. This is done in 2000, before 2000. when we started. There's no need for doing a surgery like that, but we were seeing that resistant to single agent, something like a resistance. They are not responding well, and multiparous having some problem. We are also worried. So they allowed us to do hysterectomy, which is not the treatment, but it is not condemned as such. You can try when the case is not responding, try. But these were all low-risk cases. Whether it was necessary can be criticized. But that was the situation what we faced in 1990s. Some cases we have given methotrexate, not a satisfactory response, followed with actinomycin D. 10 cases, they achieved complete remission. So we can try actinomycin D. In one of my cases like this, the patient had extravasation because of the IV push was not very clearly done, and somehow we escaped. If you happen to have this situation, infiltrate locally with hydrocortisone and local anesthetic agent. That is, some relief will be there. Severe pain because it is sloughing. So be careful in giving IV actinomycin D. Some of the cases, with the help of the medical oncologist, we refer to them about 13 cases of these 356. So they have given, after methotrexate, it was not showing complete response, they have given MAC regime at that time. Methotrexate, actinomycin, and cyclophosphamide. 7 of them had complete remission with that. And then only 6 cases of the 356 required chemo regime. So we have treated almost 90 to 95% of the cases with the single agent only. But the thing was that they were all very early diagnosis of plateauing, not even rise in HCG. We were using the graph and seeing the 95% confidence limit, making a diagnosis at early phases and starting the single agent very effectively curing the condition. Our diagnosis was GTN was only 20%. We just did not picked up everyone to give chemotherapy. It was only that much, and that too waiting sufficiently to see that whether it will have a regression. So any plateauing, we were worried because these cases were treated by us in the gynecology ward, not in the oncology, with the support of the oncologist, of course. And the cases which were not responsible, they were also happy because otherwise these cases were going to the oncologist at an advanced case, and they were telling we are relieved with the one cancer because you are looking after that much. So that was our work there with everyone there we could do along with the postgraduate. So this is how we have to establish Dr. Bhagyalakshmi, a reference center in a big teaching hospital with the help of postgraduates and many staff there. Have somebody in charge of it, generate the data like this. We can gain the knowledge as well as we can make a publication and like that. Of course, I didn't do much because I was out of the college, but still they are doing. The work is continued in our college now also. So it is going on well. So yes, this is the place where the data has come. This is part of the Calicut Medical College where I was there for almost 31 long years there, all the time there with lots of postgraduates and undergraduates. So I enjoyed my life there. So thank you very much for this chance of talking to you. I hope you could have some points taken. And if at all we have to discuss anything, Dr. Bhagyalakshmi is there, or we can give. Dr. Niranjan also is there very much in GTN. She has written on the book also, I think. Yes, very much.
Yes, sir.
We are all aware of the problem. It will become
Your chapter is there. Yes, sir.
Yeah, I know. Good. Yes,
Fantastic, sir. So it was actually a fantastic lecture, sir. As the committee chair of FOGSI, I mean, it is
sorry, Priya, I was
very...
struggling for a name. Thank you.
I know, sir. Doesn't matter.
Sorry
doesn't
for
matter
that.
at all.
Yeah,
doesn't matter, sir.
Stop screen sharing, Sekran sir.
Yeah. Yes, sir. Yes,
it was a fantastic talk. I've noted down few points, which happens to be very, very relevant for the FOGSians and for the day-to-day, clinicians who are not even in the medical college. See, not many are in the medical college, so they definitely require a very good guidance, in a day-to-day practice. So the few points which I thought was relevant for the clinicians. Number one is understanding GTN is now, there is a little change. So now I am like 26 years in practice, 30 almost years in practice. There is a little change in understanding. We were always talking about grades, and now the FIGO prognostic score is very, very important. So grade and score together goes very well to understand, as you rightly pointed out, that the grade might be low, but the score might be very high. So you should know what type of medications to be given and what type of combinations to be given. And another thing was single dose.
Bhagya, let speak one by one. Let Priya finish. Then you and final comment will be Niranjan, because he's in college with lot of experience. So let's Priya. Yes, you first share your thoughts.
Yeah. Then came up was a single dose. Like we all have been giving single dose. Methotrexate, and methotrexate. That's all what we have learned from our MBBS days, PG days, and practicing since long. So this is what we have been doing. And whenever there was, we were always getting stuck in this thing when we were seeing that SCG is not rising. We used to really tremble and never wanted to put actinomycin D. We were thinking, "Arey karne ka, nahi karne ka, ya hysterectomy karne ka." See, that was exactly what I'm saying is what a clinician faces in her day-to-day practice. And then, so now the thing is confidently, you can add up this actinomycin D. That's what I have understood very well. In one of my case, sir, my seniors had, I was stuck in such a way that the HCG level was not going down. And so that was the time, I'm talking some 15 years back, sir. And that was time when they said that we can add actinomycin D, but we really were a little scared. And then we had to send the patient to JJ. We didn't do it at our place, but we weren't very confident. That is the humble submission, because as a routine gynecologist and all, it's becoming a little difficult. But now, since you have said, and it is now understood very well, that we can do, and still there is a chance for single, even though if it is a high risk also, it is very, very important that you can, that's what you said. Methotrexate single dose, fantastically, still you can do. There is no googly, you don't have to be in a dilemma to add a multi-drug therapies. And then again, immunotherapy in the resistant GTN is again a very promising chapter. So, sir, it was a fantastic, revision. I have noted down. See, I have noted down points. Thank you very much. And fantastic, sir. Always an honor to hear from you.
Thank you.
Thank you, sir.
Bhagya, your thoughts, please. Unmute yourself.
So thank you so much, Dr. Lakshmi, for taking such an important thing, which actually intrigues general gynecologists during their day-to-day practice. They're really, really confused about what to do and what not to do. So only to reiterate what sir has told, few things for day-to-day practitioners. One is that we really, in yesteryears, when we used to do ultrasound very late, we had that typical snowstorm pattern and all those things. So now actually we don't rarely see them, because we don't see them going into pregnancy so late. So molar pregnancies may be missed in the early gestations, and most of them would land up in missed abortion or medical abortions. So it's so important to do a uterine pregnancy test once after 4 weeks of completion of these pregnancy, so that we don't miss on women who are going to develop GTN, pick them up early, so that a single agent chemotherapy regimen would work best for them. So all medical abortions should be followed with a urine pregnancy test at least after 4 weeks. So that was sir's first point, which I want to reiterate. And then about he has again mentioned that early evacuation does not prevent GTN. So if you think we have terminated early and it will not go into GTN, so that's a myth. We have to remember that. And about that weekly methotrexate is no more used, because some of our practitioners had that habit of giving a weekly methotrexate. And one very, very important point which I wanted to make here is about the 2 weeks gap between the two chemotherapy cycles. Most of the practitioners think that 2 weeks means 8 days regimen followed by a 2 weeks gap and then again 8 days, which is not so. It's the 2 weeks gap between the first doses of each cycle. So it's a 8 days chemotherapy followed by a 6 days gap, followed by again the 8 days chemotherapy. So it's a total cycle of 14 days, not a gap of 14 days. And about that FIGO score 5 and 6, sir has mentioned it so beautifully that that's a really gray area. And when you are treating a woman with a score of 5 to 6, be very, very cautious. And because it's important that we do not waste too much time. If you see that the beta HCG fall is not satisfactory, it's always better to change over to a multi-drug regimen early than wasting time. And about hysterectomy, I think now we are more liberal that women above 40, it's so easy to tell them that you can have a hysterectomy because you can go into all kinds of complications. But in younger women presenting with invasive moles where she is nulliparous and beta HCG is not responding, those cases are really difficult to treat. You have to counsel and have to be very, very, very patient. And I think, sir, because embolization is not available everywhere, we cannot give them a hysterectomy. So we have to be patiently telling them that continue with chemotherapy so that sometime the mass or the invasive mole will subside. So I think, thank you, sir, very, very much. Actually, sir is a doyen in GTN. So it's these are all his points that and we have to remember that Dr. Lakshmi, we have the FOGSI or ICOG GCPR on GTD which is ready. Sir is the advisor in my committee which is almost ready. So I think we can have a Zoom meeting and have it in place sometime.
Yes.
And one more, only one point which was important for our practitioners is, like, suppose if she becomes pregnant. Now, normally we used to get scared, no, 1 year, no, don't have pregnancy, don't have. But he said it so smoothly that in the case that she becomes pregnant, that itself shows that, systematically she is fine. I mean, so that we don't have to worry and we don't have to do a termination was another very important point. Thank you. That's all from my end.
Niranjan,
And I think
thoughts?
One, can you give me? Yeah, about that actinomycin D, I think sir has mentioned is very, very well. So I think giving actinomycin D is still not a joke because a drop of it, if it extravasates, it causes a lot of extravasation and skin necrosis. So when we are giving actinomycin D, I think it has to be in an institutional setup.
Absolutely. Absolutely.
Hello. Yeah, thank you. I think both the chairpersons, can you hear me?
Yes, Niranjan.
Yeah. Thank you all. Both the chairpersons have covered all the points, but most importantly, we had our doyen, Dr. P.K. Sekharan sir, who is the world authority. We are very proud of sir that he, being an Indian, represented us in the international body. So it's very important. I have requested if any student also or any consultant, I can see many of them are also seniors and consultants. So FOGSI is not only for postgraduate, but it is also for us, consultants or professors who are there, understanding the importance of knowledge and learning. So what can I say, sir? Your study also is a very vast series from 97 to 2005. Probably you have also added the newer cases. In my 30 years of practice, I have now seen very less cases of GTN. I see more cases of hydatiform mole. I mean, what I'm trying to say is carcinomas, very less cases of carcinomas or choriocarcinoma or invasive mole. And there, of course, we have V mole, complete mole, partial mole, which comes more commonly in our practice setup. And suction evacuation plays a very important role. Practically, if you ask me, it's a large for date uterus, and you need to keep a hand on the abdomen when you're doing a suction evacuation. And I have done that in Rajawadi Hospital, in Sion Hospital, 32-week size, 34-week size. Most of you might have done. So it's the practically, that's what we see in our obstetric practice, or a vesicular mole who has just been diagnosed with a very high level of beta HCG, and and she comes with bleeding and vesicles, etc. Now we come to the invasive mole. The next thing what I have seen in my practice is invasive mole, and there are, in those days, I remember Dr. P.K. Shah sir, my unit head, we had a young case of invasive mole, and it was diagnosed on CT that the molar pregnancy had invaginated into the serosa and it was about to burst. But unfortunately, unfortunately, we had to do a hysterectomy. We had to open her up electively also. Of course, that time the role of embolization was not to that extent, but she bled so much profusely. She bled like anything, and the whole uterus was spongy. It was totally spongy and it was totally blood. So this is what I can see. Of course, chemotherapy is the line of treatment you give. We have to give single drug or multiple drug therapy, which is always there. We do not send our patients to Tata Hospital, though it is just 5 kilometers away. We have our own oncology chemotherapy center. But you need to have, importantly, that I would recommend as a gynecologist or as an obstetrician that you have such cases who are there of invasive mole or they are undergoing chemotherapy. Please use the expertise of a medical oncologist, because it's very important. The regimes have to be tailored. They have to be given as per the weight, and they need to be properly monitored and supervised. So that's what I can say. And unfortunately, most of these patients, they lose for follow-up. So practically, you need to put a red block on the discharge card. They need to be followed up. The amount of beta HCG which we are supposed to do every 2 weekly, then they become normal, then every monthly, then every 3 monthly. So whatever the regime is there, we are following. But unfortunately, they follow up, and most importantly, they come back with a molar pregnancy. So the conception and the interval has to be a larger and longer to be understood. So these are all practical points. What I thought, madam, what I have gone through the process as a for a gynec unit. Of course, if you are in a center which is totally a gynae oncology, then you will see more number of such cases and more number of cases are referred to that extent. But I think, sir, you have covered all the points. It's a very high risk case, such cases which come to us. We have seen also the cases of post-abortal, post-delivery trophoblastic tumors. They are very rare, but there are 1 or 2 cases. One had come during COVID time, so that also we had to deal with it. Somehow they are found in young women. They are usually 35, 40 years of age, and I agree that it is a very difficult decision for them to be told to undergo a hysterectomy. Not all of them can, be better off with the chemotherapy. So these are what points I thought I should just share with you. Thank you so much for being there.
Thank you.
I had one.
Yes, Priya.
Like now, Niranjan, you said that in your case you had was about to invade this thing, rupture, and and you had to do a hysterectomy, and she bled a lot. Agar is case mein, if you had given a chemo, I mean, did you give a chemo? No, or you just took her up for a?
No. I mean, I was associate professor. This was Dr. P.K. Shah's decision, and I think Dr. P.K. Shah is himself an authority. There was no time to give her chemotherapy. She had
Agar
already.
chemo dete, so I know whatever.
No,
I'm
but
not
she
asking
landed
that.
up, madam. She landed up late. She landed up
Oh,
at such a
with the
situation.
bleeding.
It's not that we waited for her, we diagnosed it, but
We are
then
retrospectively, we can assume, presume, I mean, we can
Oh yeah, I
so
can
many
understand, madam.
things, but the doctor who is there
No, we
at
had
that
such
moment,
cases.
they are the
Yeah.
best person.
and
Of
madam,
course, of
there was
course.
hemoperitoneum. There was
Yeah.
hemoperitoneum.
Yeah,
So now
that
what,
is it.
so if you have to see, understand, I mean, when a patient is in hemoperitoneum, she's taken electively, and it was not that all the time the CT or ultrasound report is
I
the
agree.
gospel truth. It's absolutely fine, but when you
I
open,
agree.
you don't want to go for
I agree.
but mentally it was well prepared, and I think sir's decision was right. But I remember he was struggling really because it was profusely bleeding. The whole the tissue was very friable. You put a clamp, it slips off. I mean, this is maybe Dr. Shekaran sir will add something more.
Yeah. We had such a case. We had actually experienced 3 cases of invasive mole with intraperitoneal severe bleed. 2 cases, as Niranjan was telling, you can't put the clamp. It won't stay there. It's all friable tissue. It will all come.
Tribal, yes.
And with 7-8 bottles of blood, we could somehow stop with the subtotal hysterectomy and come out. The patient was then given chemotherapy and she became cured. One case, it was a localized perforation with internal hemorrhage. There was hemoperitoneuria was there. So in this case, I don't know. At that time, I made a decision to resect out that area, suture it, and then give chemotherapy. This patient came after 3 years with another pregnancy because there was a perforation which I have closed. I was again gone for a elective cesarean for that, which was not necessary probably, but it was a fundal perforation at that time. So there, of course, there was no evidence of anything there, but she was treated with chemotherapy. So these cases come in an acute emergency situation. One of the case, the patient was decided on chemotherapy. She said, my sister is getting married and I will come after 1 week. By the time she came, she was collapsed and carried from the casualty. And we know it's a case of invasive mold, immediately opened up. It was very, very difficult surgery because everything is friable. So there's no blood supply to this tumor. It is invading the blood vessels. The tumor tissue invades into the blood vessel. It's so friable. And you can't have a clamp placed there in the on anything. So it was all difficult. There's a specimen lying there. I have a photograph of that. I was searching for it. It is there. We have done all those things, 3 cases like that, 1 perforation closed. So acute way they will present with internal hemorrhage. We can give 1 shot of a chemotherapy. I mean, I have given 1 shot of a methotrexate and immediately started IV methotrexate, given blood, and immediately did a hysterectomy, which was life-saving at that time, all the 3 cases. And then we continued with the chemotherapy. And whatever scoring, whatever it is, but all the 3 responded to single agent therapy. So these are cases which can have, actually it may lead to death. It is like
You have to be very careful.
With much this thing, friable tissue bleeding like anything, once it gives away, it is invading like anything. And that is, invasive mold sometimes may require that step. We cannot salvage the uterus.
In short, I can tell sometimes Vardheims is much simpler than managing these cases. I'll tell you. I mean, it's like a catastrophic event. What you see in an obstetric hysterectomy or PPH, when the patient is absolutely unstable hemodynamically. Here, the patient is hemodynamically stable. If you are just taking at an early stage, and she starts deteriorating in front of you.
Suddenly.
You can share something. I mean, it's very rare. I mean, I'm talking something very rarest of rare, and that's what we come across. That's what I was seeing. Shah sir absolutely desperately trying to suture 15 minutes, 20 minutes, 30 minutes, and she's just bleeding. So, I mean,
We had 1 case she was on chemotherapy in the hospital. And at the morning when I came for the round, there was some distension of the abdomen. And immediately it was increasing. I knew that it was ruptured. Of the vasculama. Immediately took her for hysterectomy. So that thing can happen in front of your eyes. She was in the hospital directly. The other patient had gone home and come in a very unstable condition. We had given at that time 7 bottles, and myself and my wife struggled with others helping us and other things. That was the first case of invasive mold perforating and leading to internal hemorrhage like anything. So that can happen. All the 3 were saved, minus 2 cases without uterus was not able to be conserved. The other one we conserved, and she conceived again. So these are some of the things not very common, but we have to act immediately to save such lives. And young girls, they are all young.
Yes.
Below 25, all of them are below 25, and 2 of them lost their uterus to save their life. I had to do that. So,
sir, if I may add here, you have the largest number of cases delivery in a day. I have seen, sir, at your place, 50 to 70 delivery a day. I mean, you can imagine the obstetric, the mela which can be going on in the labor OT, in the labor ward. Bhagyashree, you want to add something, and then we can request Madam Lakshmi.
Yeah, just one thing I just wanted to add. It's already been said that when we are treating low risk GT and also giving them methotrexate and sending them home, we have to counsel them that these some kind of catastrophe can happen also during treatment. So
Yes.
they have to be a bit careful about that, because they think that it's everything is done, they are happy, they are cured. Even after the molar, we have done a suction for molar, sent her home, but you never know, there's something in the myometrium and she comes back with a perforation letter. We have had so many cases like that.
Yeah.
PK Sekharan sir, your concluding remarks after hearing all the three chairpersons, and
Okay. Now,
before we wind up, your concluding remarks. Yes.
no, it's okay.
Take home
Nothing much to do.
messages. Yes. If you
Everybody
want
knows
to again
everything.
tell the audience, yeah.
No. The chairpersons are all aware of everything, that I need not say much. And again, my colleagues who are listening, thank you very much. One is that it is becoming a rare condition. And second thing is earlier reporting of here is the problem. We want everybody to come early. But in case of molar pregnancy, they come at 7-8 weeks, we won't make a diagnosis. It has to be around 10 weeks. And then you are making a diagnosis. That is one thing which you have to be remembering. So classical findings and presentations are not there nowadays. That way. But the chance of malignancy is the same, whether you terminate early or other than. That is the other fact. Then there are the rare types of the disease, which is very, very rare. 1 in 100,000 of the events, pregnancy, you may get one such case of PSTT, which you are not. We made one case diagnosis of one curettage of the case of AUB. It was suspected and it was showing a local mass. So it was confined to the uterus and we did a hysterectomy and she is well so far. So that is it. But these cases are not going to be. Pregnancy following delivery, they may come with severe bleeding with rupture, perforation of the uterus or intracranial lesion with fits and all, epilepsy, or dyspnea and other problem with the metastasis on the lungs. So any woman of the reproductive age presenting with such symptom warrants a beta HCG or urine pregnancy test. Otherwise, you will miss it. Even I know one case was treated as bronchopneumonia. And I said, we have to just see, because the patient was also having irregular bleeding. I said, just do the urine pregnancy. It was positive. The physician was so sure that it's only bronchopneumonia. So it can be patchy, deposit in the lungs. So any woman in the reproductive age having respiratory as well as CNS presentations must have a pregnancy test done. That is the other thing in the clinical practice. Otherwise, we may miss. So things are very settled in now on how to treat, how to make a diagnosis, how to make the grouping and everything there. And even for the very high risk disease also, we are getting a cure. And also the checkpoint inhibitors or the immunotherapy is also trying to help us to solve some of these cases. There are people who are able to treat. So hope is there for any type of GTN to get a cure. And majority of the cases can retain their reproductive efficiency. That is the other thing. We had more than 180 cases of this treated case of chemotherapy cases becoming pregnant. We followed them. They were all. Only one case had a recurrent mode. Rest of them had a normal pregnancy. One had a missed abortion. And other things were all equal to the general population. So pregnancy after a molar pregnancy, even after chemotherapy, the outcome is the same. Nothing more or severe than that. They can conceive, they can think. So once you say don't become pregnant, it's not the way to have contraception. You have to provide contraception on the site. So in our OP, we were providing condoms and other things readily there so that they use it. The other problem is when she said don't become pregnant means the husband and wife has to live separately. That is not the meaning of this thing. That is how the poor people are going to take it. That they have to live separately to avoid pregnancy. That was at that time. Now we know, everybody knows what is contraception and use of it is there, easier to tell them. So that's all. I think if I told anything not covered, please ask Dr. Bhagilakshmi or Niranjan.
Thank you so much, Priya,
Sir,
Adya, Niranjan, PK sir, Sekharan sir, for sharing your pearls of wisdom on GTN with our audience. Thank you. So if anyone has to say anything, otherwise we will wind up. Bhagya, Niranjan, PK sir. So with your permission, can we close this
Okay, thank you very much.
webinar? Yeah. Komal, please stop recording.
Okay,
Yeah.
ma'am. Okay.
Thank you all. Thank you so much. Bye.